So I borrowed this. I'm going to say I stole it. Borrowed it off of a website. This is from a pediatrician and all that stuff. Roaming basically states that it's hardly ever good when the respirator's pulse or respiratory rate is greater than that of the pediatric patient. I don't know if you guys ever read the book House of God. Great book. If you never have, short read. It's funny. It's hilarious. And one of the rules, or they talk about in there, one of the rules of the house is the first pulse that you should check is your own, which is, rightfully so and all that stuff. It is a good plug. So taking control of the pediatric EMS call. Really, there's, three things that kind of sort of, starting off before we even, start the call. And that's one of the reasons why you're here right now. It's part of the preparation and the practice side of it. And then so much of, into the perception, which we'll talk about in a little bit. But the preparation, the practice, repeating things over and over again. I ask a lot of questions, so it's just how I am. So a pediatric 1-year-old weighs how much? You're going to a code. You just got a call. You have a 1-year-old cardiac arrest. How much in your mind? How much does that kid weigh? 16 kilos. Okay. So weight pound-wise. Do you ever think about this? So I have what's called a 1-5-10 rule. So a 1-year-old, a 5-year-old, a 10-year-old is approximately 10, 20, 30. Now again, this might be, I don't know, Ayersville, if they have a lot of bigger kids out here and all that stuff. So you do have to kind of sort of take into consideration, the size of the kid. So ideal body weight, or what's based upon the Broslow. 1-5-10. So 1-year-old, a 5-year-old, 10-year-old, it's approximately 10, 20, 30. So 1-year-old is approximately 10 kilograms, a 5-year-old is approximately 20, and a 9, 10-year-old is approximately 30 kilograms. So thereby that, if you already know a weight, everything in pediatrics is weight-based. Your angst and your anxiety is already, if you can just that and keep that in your mind, most everything else really falls into play. So part of the preparation, the practice, all right? What we're trying to do is trying to figure out ways to stop the chain from breaking. All right? Again, going through that whole rote over and over again practicing. So on the prep side of it, or the prep, which is the first one is the practice, and you have response, equipments, and then down, the protocols and all that stuff. And the only way with protocols is reading them. I know it's a short read, but it's like, how do you eat an elephant? One bite at a time. All right. So the same thing with the guidelines, the protocols, and all that stuff. You can't sit there and read it. I've written it so many times, I know the guidelines. All right. And the only ways for you guys to get familiar with them is, take a page at a time, sit down on the toilet while you're walking, reading, whatever, from that aspect. So using prep, that's basically half of it, seeing control, okay? Hopefully dispatch will give you guys some information. Otherwise, if it's a 6-year-old, cardiac arrest, whatever, talk about it, and we'll, in a second, is start quizzing each other, or start, if you're with your partner, really prepping yourselves. What are we to expect? What are we to see? Okay? So much that you can do before you even get there. So what we're going to do is we're going to talk about pediatrics. We'll talk about the assessment triangles, what's called the non-accidental traumas. All right, your child abuse and all that stuff. Ingestions, fevers, seizures. The inconsolable crying child have mnemonic called "So a bitch," which will help kind of sort of what to think about with that inconsolable child. RSV, croup, we're in that season now. And then epiglottitis, it's there but not there. And a lot of it's because of the immunizations and the vaccinations that have occurred back in the 1980s. So we don't see as much with epiglottitis, which is a good thing for us. Pre-hospital, there was a lot of sick kids that got intubated and all that stuff just because of this, the Haemophilus influenza, bacteria and all that stuff. And again, any questions? Stop me. Talk. We can talk about, go off topic, and I don't care. So notable vital signs. All right. By the end of this, I expect you to memorize this. You'll be quizzed on it. Okay. Again, here it's really trends. Okay. If you look at trends and you know, newborns, they breathe really fast, and as we get older, we don't breathe as fast. Heart rates are really fast, and then they're not quite as fast. Blood pressure are really low, and then they go up. So it's more along the lines of trends, and there's some different formulas out there that you can say, 70 plus age is what the ideal, newborn up until, or their age per month. Plus 70 will give you your systolic blood pressure. Don't worry about that, okay? Really look at trends. Knowing that a newborn, he can be breathing up to 60 a minute, and that's normal. Heart rates, 130s to 140s, up to 200s, and that's normal, okay? And then goes down. That's the biggest thing. So when you look at the kid, and when we talk about a little bit with the PAT, it's, yes, the kid looks good, but he has a fast heart rate, he's breathing fast. Is that really a bad thing? And again, just talk about the age and the weights and all that stuff. If you don't have a Braslow's, your 1-year-old, your 5 and 10, again, just go back to reiterate your 10, 20, 30 rule. This has really saved my rear end many, many times. I used to love Grey's Anatomy. I've watched it forever. All right. So whenever I lecture or whenever I give, I always start off with a little bit on, anatomy, physiology. We've always forgotten it. Some of you probably haven't dusted off the EMT book in a while. Over and over again. The only way I remember a lot of it is because of the lecturing. So pediatrics, size, okay? They got big heads, little bodies, okay? Their neck's not well developed. They don't have as much blood. They get their abdomen, their skin, and all that stuff is really close. They're lower to the ground, so they have problems with heat exchange. So there's a lot of factors to take into consideration. Heads, 60%, okay? The majority of blunt injuries is the head. We know, the little, your toddler that is just starting to walk, what happens to them? They trip, boom, okay? They take the face plant over and over again. That head is like the lawn dart, okay? It's a projectile, and that's really what they go. They have not as thick skulls, so the problem there is the potential, especially with the fontanelles. Fontanelles don't close until the age of 2, so the potential risk of damaging the brain itself more from the impact because the skull's not protecting it. And then from there, smaller faces, which in turn makes it difficult, for our EMTs or our advanced EMTs and paramedics to be able to intubate. Next, they have a greater laxity. Again, smaller neck, big head, okay? All the spinous or the ligamentous processes and all that stuff are not working, or they're not as strong. So what happens in a car accident? So you got big heads, small necks that with lax, okay? Car accident, crash, boom, what happens? Exactly, they got the bobblehead going, okay? This is one of the reasons why kids should be rear facing, okay? What is it, 20 pounds in the age of at least 1 or 22 pounds? It's been a little while, okay? In the Pediatric Association now is saying as long as the kid can be in a rear facing car seat, that's the ideal, until they outgrow it, is really the ideal place, because they look at, trying to prevent neck injuries in the kids and all that stuff. Always think about from the aspect here when we talk about airways. If you lay their head down, they have a big occiput, so it's going to push the chin towards their chest. So you might have to put a pad or something or a towel roll even under their shoulder blades, okay, to help them for breathing and all that stuff. Or if you're going to be potentially intubating and all that. The ribs are more horizontal versus the adults. Our adults, they go at an angle. There's wrap around the body. They have small intercostals, or the intercostal muscles aren't working as well. And from there, the breathing side of it, okay, what's the largest muscle in our body, or in the abdominal for breathing and all that stuff? The diaphragm, okay? They rely on the diaphragm for everything, okay? So how do kids, what are kids predominantly called? Belly breathers, all right? They breathe with their belly because of the diaphragm and all that stuff. It's a bad sign, or it's ominous sign when you see more of the chest and less of the belly in the kids and all that stuff. Mediastinum is more mobile, and then from there, thin chest walls. If you listen, a lot of times you can hear upper airway stuff from the nose coming down to the chest, where it might sound like they're wheezing or might have bronchi and all that stuff, just because of how everything's transmitted through. Cardiovascular, heart rate. Okay, up until 1 to 2. Okay. Actually, going back to the chest and lungs, one answer I forgot, they're what's called obligate nasal breathers. They usually see to about the age of 1, right? Because most of the time, if you think, pre-industrial time period, how did kids eat? What was their source of nutrition for infants? Nursing, okay, the breast, okay. How do you eat and breathe at the same time? Through the nose, exactly. So to about 1, if they have clogged nose and all that stuff, they can't breathe, which means they can't eat. All right. So a lot of times for them, when we talk about a little bit with the bronchiolitis, you get your 6, 7-year-old this time period when it's starting to get cold, RSV, non-RSV, bronchiolitis. They got the runny noses and all that stuff. If even the simplest thing of taking the blue bulb syringes and suctioning their nose out, it saves them, okay? You guys can cure a kid just by suctioning the nose. And then you're a hero. Mom pats you on the back. Yay, you saved my kid. All right. So heart rate, they have a limited reserve. We won't really talk about the, actually, we can. Cardiac output equals what? Told you, that quiz. Heart rate times what? Stroke volume. All right. So stroke volume is the amount of blood that squirts out per beat, and of course heart rate. Okay. The cardiac output is heart rate times stroke volume. Stroke volume is based on 3 things: preload, afterload, contractility. Different story, different topic. All right. Really, though, the biggest, they don't have a big heart, so they can't circulate a lot of blood. Of course, they don't have much blood anyways. So they get a very small amount of blood to be able to squirt through the heart. So how do they maintain their cardiac output? Through their heart rate. That's why kids, they can teeter at 180, 200 beats per minute for an hours on end. Okay? And then what happens, though, to them? They're done. Okay? They crash fast and hard. All right, so be very careful and ominous. Again, you get a kid that's beating at 200 a minute. 1, find out how long it's been going on, and then prepare for the worst, because it's going to happen. It's going to happen quick. Bradycardia is not a good thing. It's usually due to lack of oxygen. And then, of course, with the blood pressure, they can hold it a little bit longer than adults. And then from the aspect of the blood volume, larger, it's proportionally larger because they have smaller bodies that we'll talk to in about a second. Their absolute volume is lower. Right. So a newborn, they have about a soda can, 12 ounces. Your 60-pound kid, which is about what age? 10, 11, okay, because 60 pounds, how do we get to kilograms? 2.2 or half, whichever one, okay? And then going back to our 1, 5, 10 rule, okay, so 1-year-old is 10, 5-year-old is, okay, 9, 10-year-old, 30, okay? So 1, 5, 10, and that's about that. And then, of course, once we get to 125-pound adults, all that stuff, they have a couple liters of blood. Small blood volumes, again, talk about the rapid blood control, and then they go, quickly through the sudden irreversible shock. So they're doing well, and then they step over the cliff and plummet, and you can't get them back. Blood pressure, again, from the aspect, not always a good thing or be able to control. So what's a good way to measure how well their circulation? And we'll talk about this a little bit with the PAT. Look at them. Specifically, what are you looking for? Pink, warm, and dry. What else can you check for? Skin turgor, cap refills. Okay. So in a black child, where's another good place to look at? Sclera and gums under the tongue. Have them lift up their tongue. Look into the buccal mucosa and all that stuff. Low consciousness, talk about that. Cap refill, just push it down and see how long it lasts. Ideally, it should be no more than less than 2, okay? Respiratory, the whole aspect with the tidal volume, they have small lungs, small chest, so they can't take in as much. We know this. And then from there, the oxygen demand is higher, okay? Heart rate is equivalent to metabolic demand. The faster our heart rate is, the faster our metabolic demand is. And that's one of the things that when I talk about different things like STEMIs, why in the guidelines we give medications to make patients not as anxious and not have as fast as a heart rate. Because if I can lower the heart rate down, I know that I don't need as much oxygen. Same thing with kids. If I can slow them down a little bit, don't have them breathe as fast, they're not going to have as much problems with needing the oxygen. Airways, again, big heads. Occiput's big, so it tilts the head forward. Okay. They have big tongues, small airways, small neck, which in turn leads to all the problems inside the airway and all that stuff. They get a floppy epiglottis, which is omega-shaped, and then the cricoid cartilage is the narrowest point. In an adult, what's the narrowest point? The vocal cords. Yep. So the vocal cords itself. So it's a little bit past the vocal cords, and this is one of the things we talk about ingestions a little bit later. Okay. Your little grape. Okay. They suck the grape. Where does it go? It gets past the vocal cord, and then it gets stuck. All right, right in the cartilage and all that stuff. Absent-minded breathers, again, we talk about the obligate nasal breathers. Neck overextension can sometimes cause problems with the glottis, and then, just opening their jaw, giving the good lift, head tilt, chin lift, grabbing again, if you have to reach in there, grab the mouth and the tongue and lift that up, put in your oral airways, NPs, your nasopharyngeals and all that stuff to help out. Big tongue, small airway, the cricocartilage there, that's usually the place for blockages versus the adults, just different. And then from there, the other aspects, when you start drawing your lines through everything for axes, I'm going to talk about that right now. Obligate nasal breathers, diaphragm breathers, abdominal breathers, weak accessory muscles, and then, what is deemed an increased respiratory rate. 30 for a 4 or 5-year-old is normal. Okay. Now, a 4 or 5-year-old that's breathing 60, there's an issue. Okay. So, respiratory failure, leading cause of death in pediatrics. Okay. They don't die from sudden cardiac arrest. They don't die from STEMIs. Okay? They die from lack of oxygen. Correct. Yep. Anything and everything that causes the lack of oxygen. All right. So in the abdomen, they don't have as much abdominal muscles. They're missing the linea alba. So you can, walking, my little 5-6-month-old, I can go and push on his belly. You can feel anything. I feel the poop. I feel the liver, the spleen. You can almost push back far enough and feel the spine and all that stuff. they get a big liver, big spleen, and all that stuff, which that's, for accident-wise, except for the head and the abdomen, blunt injuries that really takes the effect because they have such huge livers and spleens and all that stuff. Not as developed, age of 8, that's how the brain is working. So I think my dad screwed me up a little bit when he was giving me beer at 4. Maybe not. Increased risk of damage from the aspect, I don't know how it is out here, but in Toledo, one of the things that they check by the age of 9 months with lead screening and all that stuff. Some of the lead plants there, all the homes that were lead-based paint, things to take into consideration. So if you walk in there and I'm not talking about, I don't have milestones or in here or anything like that, but things to take into consideration. Okay, when should a kid be able to sit up? 6 months. Okay, when do they start rolling over? 3 to 4 months. Okay, so sitting up, or start rolling at 3 to 4, sitting up by 6. When do they start pulling up? 8, 9 months. Okay, and then walking, a year. Okay, so those are one of those things when you get into your sample history and the questions, and to be asking. Okay, you got a little toddler. He's 2, but he's not. Not walking. Why? Okay, things to be asking questions and all that stuff. Other information. Extremities, they have small bones. The growth plates don't really, till about the age 17, 18 is when most of the growth plates are fused. And then the IO axis, getting into the anterior proximal tibia. Did hear a lecture today I'm going to send to Chief, where they actually talked about doing IOs in the distal femur as one of their places, the lateral distal femur for little ones. Yeah, as another potential spot and all that stuff. Correct. Yep. Skeleton again, they have more connective tissue. The bones are, the connective tissue is stronger than the bones, so they don't strain or sprain. They break more. Then, of course, depending on what type of fractures, when we talk about the non-accidentals, the rotations, green strict fractures, and all that stuff. Usually a force, if it's a nice clean break, there's a lot of force involved with all that stuff. Skin, thin, elastic. Usually, or from the aspect, they're like the adults. They have the skin as the largest organ of the body. But it's also from the aspect they have small body mass, lots of skin, so they don't have the ability to control their temperatures and all that stuff. So they cool off real fast or they heat up real fast. There's so much truth in that. If you're not a parent. And 3 o'clock, and 4 o'clock, and 5. All right. Any questions on anatomy phys? Again, a lot of it's just kind of sort of review to kind of sort of remember you guys to remember and all that stuff. Going, oh crap. All right. So infants, first year of life, anything and everything is physical stimuli. They want to see, they want to touch, they want to feel, and where does everything go? In the mouth, except for food. That's actually one of the talk about Facebook there. My wife showed me, she's like, if it's food, it goes, don't want it, in the hair, the clothes, all that stuff. Not food, goes into the mouth. Actually, I need to find that to put it in here. Crying is their form of expression. Under the age of 2 months, they have limited behavioral, they have brief periods. They really don't have any social smile and all that stuff. They're there. 23 hours of their day is sleeping. The other hour is eating and pooping. All right? Exactly. All right? It's really from the aspect, transportation, histories. So anything under 2, if they're talking about fever, if the kid has a fever of any sort, mom says he feels warm, which they've actually done research on, that mothers going, yeah, he kind of sort of feels warm. You know, they've actually done it where they're fairly accurate on their temperatures and all that stuff. So if mom says he has a fever, kid goes from the whole newborn fevers and all that stuff. 2 to 6 months, they get a little bit of social smiles. They start tracking. They have the cry, and then the rolling over and the sitting and all that stuff. Assessment under the 6, usually give the kid to mom. They don't have as much as stranger anxiety, but mom can usually, they can hold them. You know, it's easier to control and all that stuff. Yeah, there's always factors of that. Yeah, correct. Yep. And then actually with this EM rap that I was listening to today, one of the anxieties for the kid is actually the anxiety of mom and everything that you were just saying there. Examine the chest. Why do we want to do the chest and abdomen first? Make sure they're breathing. Okay. Correct. All right. So you want to know what the rate quality of the lungs and the heart is, because once you start touching anywhere else, what are they going to do? They're going to freak out. They're going to start crying, and then their heart rate's going to get jacked up. Their respiratory rate's going to, it's going to get all messed up. So from that aspect, if you can go to the chest and lungs first, push on the abdomen, belly, and all that. 6 to 12, they get a little bit more social. They don't start with, they know who mama and dada is. They play with toys. Everything goes into the mouth, and then they become, start becoming mobile, crawling, moving, pulling up, cruising, all that. Caregiver, let them, if you have time and if the kid doesn't look bad, if you need to, let them have your stethoscope. Okay, okay, I don't want it. They put it in the mouth and okay, it doesn't taste good, and then give it back. And then, again, building that repertoire or the early ability to examine the kids. And then the head to toe or toe to head exam. And again, they don't want you to come into their face first, because what do they fear? Us. All right. So if you pinch on the toes, play with the knees, tickle them, then they start going giggling, laughing, and all that stuff, and it makes things a lot easier. Terrible twos. Mine's already there. They don't like separation. They don't like being restrained, but they're easily distracted. Okay. Most parents nowadays have smartphones, and on the smartphones, what do they have? They have all the games. The kids know that. Okay. That or movies or whatever, which so parents can be our allies when it comes this age time period. Lots of ability. They're curious. They have opinions. Mine's just learned the word no, which is not a good thing for him. They don't understand logic. They do trial and error. Put the fork into the outlet. That's not a good thing. Okay. Call that it's a self-correcting error. You hope. Yes. And that's my fears. I think it's going to be a couple times before he figures that one out. Usually with the kids, start off with across the room, look at when we talk about the PAPs and all that stuff in a little bit, get down to the child's level, use play distractions and all that stuff. Really they like low, because once you tower above them, they get intimidated, they get scared, and then they run away from you. Talk, reassure, explain, the toe to head exam again, and then whatever hurts, leave that for the last. They don't want the ouchie. Preschoolers, 3 to 6, they understand directions. They can tell you what hurts. They don't like to be, again, the pain. Let them have the equipment. With the whole aspect too of the curiosity. From the school age, 6 to 12, they have age of reasoning. You can talk to them like little adults. They should be familiar by this time with what the physical exam is. And this is where we start getting more into the head to toe exam and all that stuff. Misconceptions about their bodies. They don't like pain. I don't know how many times I've had, the 4-year-old run just come in. No, ouch, ouch, that's gonna hurt, And then they ask you, what's the one question they ask? Is it gonna hurt? And yeah. That's the first, I don't know how many times, walk in the room. Am I gonna get shot? Am I getting needles? No, not right now. Maybe later. And then they, of course, when they get sick, they want either mom or dada. Yes. Somebody hold me. Just hold me. Speak directly, simple instructions, praise, avoid ridicule. Sumo kids. Sumo baby. Yeah. Oh, wow. Gestational diabetes, I assume. Yeah. Minimize lag time between, the what's going on, performing any procedures. If talking doesn't, if talking fails, if they don't like it, sometimes you just have to resort to the papoose and restraining the kids. Adolescents, 12 to 18, strong feelings, they like their privacy. Of course, they do understand pain, and you can explain things. 9 times out of 10. Yeah, exactly. Yeah. My sister's a pediatrician, and I tease her all the time. I'm like, kids are just little adults, everything about them. They're just little adults. And she's like, no, they're not. It really are. But for the most part, everything that we do, everything stems back to BLS. We can't do anything. I can't do my job without you guys, and all that stuff. Or back to the basics. All right. So ABCs come first on everything. This assessment, pretty much, we're trying to figure out, what are the life threats? Do we need to stay and play, or do we have to load and go? All right. So when you walk into the room, and we'll talk about the pediatric assessment triangle in a second, it's really from the aspect is, are we going or are we staying? All right. So the doorway assessment, what's the 3 parts of the pediatric assessment triangle? Yep. Worker breathing, or breathing part of it. Yep. So before that, appearance, breathing, and ABC. So circulation. All right. So on the appearance, how do they look? Are they sitting up? Are they laying down? Is it a 1-month-old? Is it a 5-year-old? Can they roll? Do they look cyanotic? Anything and everything. When you open the door, what's your first initial impression of that kid? Breathing side of it, okay? Can you hear them? We know bad wheezing kids across the room. All right. It's the ones the asthma kids that when you look at them, they got nasal flaring, they got their intercostal retractions, they're belly breathing, but you hear nothing at all. That's bad. Those are the kids that scare me. All right, because those are the ones that are going to dump and crump real fast, like. And then of course the circulation. What does the skin color look like? Cyanotic. With cyanosis. Blue, ashen. Ashen's gray. Okay, paler, whatever. All right. So appearance, how do they look? What is the breathing? And then of course the circulation. All right. So tickle me elmo and all that stuff, general appearance, tone, interactiveness, are they consolable? And then look, gaze, and then speech and cry. And a lot of times consolability is giving the mom and dad, okay, can mom and dad console them? Okay. If mom and dad can't console the child, guess what? It's time to go. Something bad. Okay. And it's usually mom. If mom can't do them, from that aspect. And then, of course, the whole speech, cry, and all that stuff. Work of breathing, we know that it's more informative than the absolute respiratory rate. So what are we looking at with the work of breathing? Rate, retractions. Okay. Retractions where? Intercostals, where else? Supraclavicular. Okay. Diaphragmatic retractions. Okay. And then the nasal flaring. All right. When kids start nasal flaring, they'll get retractions first. Nasal flaring is start getting into a late sign. And then the head bobbing. Exactly. Work breathe slow means that they're having problems with decomposition. Skin color, just some aspect of circulation, early sign. So acrocyanosis, which is, sometimes you'll hear that word. They'll get their fingers, their nose, their toes, all that will be blue, but their core is nice and pink. Newborns are really known for this. For infants and toddlers and even kids, when is this a normal thing for them? Will they get their fingers and will they have the acrocyanosis? It's old, June, July, they go to the pool. It's 8 o'clock in the morning for swim lessons. You get out, their lips are all blue and their fingers. That's a normal thing for them. So don't always take into consideration of just that. Look at the whole appearance and go from there. Initial assessments, okay. AVPU stands for what? Okay. And how do we calculate a GCS? What's the 3 parts to the GCS? Okay. So how many points do you get for eyes? 4 for eyes. Verbal, 5. And then motor for 6. Okay. So EVM is how I remember mnemonic. So eyes, verbal, mouth, eyes, verbal, motor, or movement, whatever. So top down, 4, 5, 6 equals 15. So even a rock gets a 3. Okay. I've seen people come up to me and say, yeah, he has a GCS of 0. Okay. Okay. So a dead person has a GCS of 3. And for another day, breathing, of course, airway, do they hear sounds, initial your central colors, and then talk about the skin color, cap refills, and all that stuff. So really the question is, what you're asking yourself, is it critical? Is it unstable? Is it potentially unstable? And then, of course, is it stable? A lot of mnemonics. Right. So on the critical side of it is really, do they have any problems breathing, circulating? Do they have a pulse? No pulse? Crap. That is unstable. Got to go. All right. Are they breathing? Nope, they're not breathing. Oh, crap. Got to go. All right. Bad traumas, cardiac arrest, respiratory arrest. Okay. That's your load and go. Okay. And the best drug for this situation, diesel. Okay. Oxygen and high flow diesel. Lots of it. On the unstable side of it, compromised, they might have some breathing problems, the circulation, they might be a delayed cap refill, but they might be breathing, different reasons, from the injuries, respiratory. This is with your bad asthmatic kids, some of the trauma, they're hemorrhaging and all that stuff, bleeding blood, your near drownings, unresponsives. Potentially unstables, air compromise, they look good, but it's that mechanism of injury. They fell 15 feet from the tree, but they're running around. Well, is there potential badness and all that stuff? The high-speed car accident when everyone else in the car is dead, but the kid is shaking the rattle. Again, a lot of potential badness. Exactly. Minor fractures, pedestrian struck, but they look good. We'll talk about that in a little bit too. And then, of course, the stable. Kids will look good. Everything looks good. That's where we can, stay and play and go from there. get your sample history, get more of your information. So on the respiratory distress, appearance normal, work of breathing is increased, and circulation, okay, might be normal, might be a little bit cyanotic. All right. So on respiratory failure, the appearance, pale, okay. Abnormal. Breathing, increase, decrease, problems. What? Can be either, okay. I got that one backwards. So it can be increased, and then of course the circulation can be abnormal also. Shock, appearance, normal, abnormal. All right. Breathing. I got choose. Yeah. Yeah. Breathing normal. And it's usually from the shock, it's from the aspect, depends on what type of shock it is. If it's just like a hypovolemic, septic shock and all that stuff, where there's skin color they don't have, it might be pale cyanotic, but it can be abnormal. Right. So talk about shock from the aspect, sustained tachycardia is always a potential problem, delayed capillary refills. What's tachypnea? Yep, rapid breathing. And then from there, the peripheral constriction, cold clam extremities. That's really what causes our cyanosis. Lay shock, weak pulse, decreased loss of consciousness, and then blood pressure. Okay. If you get a 15-year-old that has a blood pressure of 70, good or bad? Bad. Okay. So stuff like that, and again, going the whole aspect of, if you want to remember all the vital signs, please be my guest. I'll give you a pat on the back and a brownie. Crashing kids. Braslow, that it was, has been the tried and true method. There's some other things coming out now that's out there, the crash carts. Again, I just like my 1-5-10 rule, which really helps out, and then I can calculate everything else. If you have smartphone users, there's a good app, Potpourri. It's a wonderful thing to have and all that stuff. All right, so trauma. We know 89% from the is blunt, penetrating as not as much, unless you just happen to be living in Toledo watching cartoons and someone does a drive-by. That's always a bad thing. Leading cause of death for children. Different than adults. A lot of it's based upon mechanism of injuries and, of course, patterns of injuries. From the aspect here, infants usually childhood use and burns. When we talk about some of the things in the future, you can tell what type of burn and how the burn occurred. No, I just it was the water was hot or whatever. And then toddlers, burns and drownings. School age, as we start, they become more mobile. And then adolescents, car accidents, because they're invincible. So from the aspect of an occupant, internal injuries, okay, what year is this car? Okay, so we know now this is one of the fractures that's called a chance fracture. So it's a T12L1 fracture, named after Dr. Chance, who found it. And what they did was kids, this is the whole reason why they have to have a shoulder harness now, because they're getting folded over and they're actually having a wedge fracture. In that region, T12L1 there's one of the parasympathetics that helps you with urination and pooping. So when you fracture those, kids have problems with peeing and pooping later. That's the whole reason with chance fracture. Restraints, of course, the problems, car seats. If they can't wear, they should always be in a proper size car seat, booster seat, and all that stuff, which I'm a huge stickler. Otherwise, if they're unrestrained, they become mobile projectiles. They hit anything and hit everything. On the pedestrians, there's what's called the 3-strike rule, or the 3 hits. So what happens is you have the kid, they get hit by the car, okay? So that's hit number one. From there, they hit the car, okay? They bounce off the car, striking the ground, okay? So hit number two. And then inside the skull or inside the body, everything gets jarred and jostled around. So that's the third hit. So this is one, kid hitting the ground is two, and then of course each thing shaking inside is three. And depending on where it is and all that stuff. Most of the time with kids, okay, so cars coming at them, what do kids do? What? They don't. They freeze. Okay, so adults will look into it, they will actually turn and look into the vehicle. So that way you can know. Kids, they will either try to run or they freeze and they get the side impacts and all that stuff. Falls, anything twice their height is always the biggest aspect. I don't know how many times my kid's fallen off my bed, and which is definitely twice his height. He's fine. Bicycles, helmeted, just from the aspect, if they're helmets, when we fall, what do we try to do? Brace ourselves. What are we trying to protect? Our head, okay? Natural instinct. Anything and everything to protect the face and the head. So the cord, the core, protect the core, protect the spinal cord, protect the head. Otherwise, unhelmeted, they get the scalps, these are the head injuries, handlebar, internal abdominal, there's the aspect where you can actually have pancreatitis or injury to the pancreas from your handlebar injuries. Complication airways, more likely with respiratory problems, okay? So seat collar in place, the kid's strapped down to the board, they can't move anything, and then like everything else, kids get scared, what do? They freak out, they're strapped to the bottom, and then from there, they freak out, and then over time, what do they start doing? They're trying to get out, they're hyperventilating. When a kid starts hyperventilating, gasping for breath, what do? They puke on you. Okay? So now they're on a backboard, they can't, and they, kids, they puke at anything. Exactly. Burns, rules of nines, of course, airways always a huge thing, respiratory problems, and then, pain management is a huge, huge thing for them. Two different ways that you can assess the burn patients. One's using the palm surface, okay? Not your palm, it's the kid's palm, okay? Or the other aspect is the rules of nine. Child abuse, okay, we have an obligatory law, okay? If you suspect it, what should you do? Report it, okay? You don't have to confront mom or dad or anything else. And a lot of times, when they come in, and I tell parents, hey, by a law, I have to, this looks like, okay, something that's concerning. I have to let CSB know, okay? They do all the field checks, they do everything else, okay? You don't really make the parents uncomfortable and say, this just looks like something, and by law, we have to report it, okay? And then they can go from there. So typical, is the injury typical? What is the type? Do they have multiple injuries, multiple burns, different burns, patterns? I'll show some stuff in a second. Is the caregiver behaving appropriately? Is dad pacing in the background, which I don't know how many times I've been on scene. Kid looks crap and dad's just pacing back and forth because that ultimately it is, or something like that, or the babysitter that, oh, everything's fine, stuff like that. Drink and drug abuse. Multiple injuries, different marks, delay seeking care, is the child clean, appropriate weight? Burns on hand and feet, which I'll show some pictures. Any decreased level of consciousness, rectal and vaginal bleeding, of course, is always a potential problem and concern from that aspect. And then for you guys, so much of the questions when you bring kids in, especially traumas. One of my questions I want you guys, what did the home look like? What is all that stuff about? Or tell the doctors that. So when you get the cotton glove, the stocking gloves and all that stuff, the burning, or this one, from the aspect where you have the saving the skin folds, that kid is drawing their legs up because they're trying to get out of the water. Okay, this one, what's this? What? Beating with what? Switch or belt? The cable. You get the circular marks, the cords of the cable and all that stuff. Of course, screaming is not always. There is, have you guys ever heard of cupping or coining? Okay, so what's cupping? Okay, what's some other potential things with cupping? But a lot of times what they'll do is actually they'll take a glass cup, they'll heat it, put a match on the inside of it so it heats, and they'll put the cup, they'll take the match out or the lighter, and then they'll put and so you'll see a whole bunch of rings on the kid. And what supposedly it's, trying to draw all the nasty out. Or the coining where they'll take the coins and they'll strip their back and the arms and all that stuff. Okay, yeah, it's a ritual thing. So to take in a lot of Hispanic, this is common Hispanics and all that stuff. So something to take into considerations. This is better with a Michigan, where he's a little Michigan kid. Sorry. And she did it. All right, kids. They eat everything. They will try anything. Okay. Accidental, 75% under 5. Once you get into overdoses of the adults and all that stuff, adolescents, teenagers, it is, suicide until proven otherwise. Common things, okay. They know that this tastes good. Oh yeah, by the way, that looks just like that. Okay. This is why, antifreeze and all that stuff, it tastes good, and they will drink it. Funny looking, anything on the floor, batteries. I don't know how many batteries I've helped get rid of. Sometimes it's like, it'll poop out. Remove safe environment, control the airway, circulation. Are they have any problems with the myocardial? From the aspect, what history, what do you guys want to know? You get called to a scene for ingestions. What should you be asking? What it was? How much? When? Yep. Okay. Correct. Correct. All right. Yeah. Bring the bottle with you. Always. What? How much? Are they vomiting and causing coughing, seizures? Are they altered? Why don't we do Ipecac? Okay. So if it burns going down, what's going to happen? It's going to burn coming back up. Okay. That's why we don't do milk or anything like that, or the whole thing. They drink acid, so I'm going to give them some alkali. We're not, we're not plain pharmacists. You've been the one, huh? So what is Skittles Party? Farm parties? Do you know what it is? Have you ever heard of it? Yep. Yeah. You'd be amazed at how many, when I do my street lugs and I talk about Skittle parties, I'm like going, what? They do that? Yep, they do that. Yeah. So ABCs, don't forget your coma cocktail, your dextrose, oxygen, Narcan, and thiamine. Charcoal, from the aspect we're not really doing charcoal and it's out of the guidelines now. It's purely from the aspect, give charcoal, what do kids do? They're not going to drink it, or if they do drink it, what happens? They puke. It's going to be all over the back of your ambulance. Okay, so now I have a kid that's puked, that has a black mouth, and now starts having respiratory problems. Who wants to intubate that kid? Exactly. Bring it. Bring the patient. Treat the patient, not the poison. This is a nice play on words. Kidnapping versus kid. Yeah, okay. Temperature, fevers. Okay, it's not a disease; it's a sign of something. All right. So in kids, what do we kind of sort of? What's the fever cutoff? 1.5. Okay. What age? What? 2, 3, 4, 5, somewhere there. Okay. I even go up as high as 104. Okay. So if you have a kid that's 103.5 that's running around destroying everything, are we worried? Okay. So if we have a kid that's 100.5 but looks like death warmed over. Okay. So again, it's not always the temperature. And from the aspect with the elusive temperature rise, 104 in child, an infant less than 3 months, anything over 100.4 is deemed a neonatal fever. Okay. And these kids, they get tapped, they get lines, they get labs, they get x-rays, and potentially stay in the hospital for 21 days. Been there with my kid. Not a fun time. Nothing. 21 days of antibiotics for nothing. Hey, that's what happens when you have a temperature of 100.8 at days number 3 of life. How do they look? How is the fever? Does the kid look good? Are they listless, weak? Are they, from the aspect, are they consolable, not consolable? Kids that are talking, playing, all that stuff. Aspect of, asking, have you given anything, Tylenol, ibuprofen? Aspirin's no longer because of the Rye syndrome. And then some of the parents, of course, they're still doing tepid baths. I've still had parents with, I use the alcohol, rub them down with the alcohol and all that stuff. There's still a lot of wives' tales and all that stuff out there. Exactly. And it doesn't. Dehydration for kids, the aspect, this is why 2 things that parents bring their kids to the ERs, or for you guys, pain, okay, and then dehydrations and all that stuff. For diarrhea and vomiting, 10. All right. I don't know how many times. How many bouts of diarrhea? Oh, they had 1. Oh, they had 2. And they're, breaking everything in the ER. Exactly. So from there, why did they use 10? It was arbitrary. Things that we kind of sort of think about, though, once they get above 10, are they having electrolyte imbalances? They start pooping out all the bicarb, potassium problems, and then 5% for your kids. Once they potentially lose 5% of their body weight, can have a lot of issues for them. Because remember, okay, how much does a kid, how much fluid do they have? 12 ounces for a newborn, okay? And a 9, 10-year-old has how much? A liter? So they have between 12 ounces and a liter. So take that into consideration. Eval, again, from the aspect cardiopulmonary, evaluation of the dehydration, and you get the history. What does it look like? Is it bilious, which is what? Yep. Okay. It's like neon yellow color. Non-bilious. Is it bloody? Blood tinge is the diarrhea. How much is it? Watery diarrhea. Voluminous. How much? It's comes out the diaper, down the car seat, down the and it's falling out the car as we're driving down the road. There's a lot there. Okay. Bloody diarrhea and all that stuff. That's a bad day. Focus history, of course, from the aspect of abdominal tenderness, anything for focal infections, estimate the urine output. So kids, if they're still in diapers, how many diapers a day? 4 to 6. Okay. So 4 to 6 wet diapers a day, what they should be using. So one of the, again, those questions that really gives, your mom says, well, he hasn't peed in 8 hours, or he's only had one diaper in the past 24. That's a bad sign. And then, of course, ask mom, dad what they've done. All right. So asthma. It's all perspective. That's a good perspective. Maybe the kid was playing around. I like that. You know. All right. So asthma. 3 things that causes asthma. Environment. Okay. What are the environmental and all that stuff causes within the body? Is that a hiccup? Okay. Sorry. Right. So within the body, the 3 things that we treat for. Okay, so bronchial constriction. Okay. What? Histamine. Okay, which that goes along to the bronchial constrictions and all that stuff. All right. But histamine also causes what? You twist your ankle, what happens? Swells. That's a histamine. That's histamine release. Yep. So you get edema. Okay. And what are they trying to cough up? Phlegm. Okay. So you get the bronchial spasms, bronchial constrictions, and all that stuff. We get the bronchial edema. It's all pissed off in there. Okay. You get histamine release, which in turn causes edema, and then you get the mucus plugging. So normal airway, muscle contractions, basically all the smooth muscles or all the muscles of the lungs in the bronchial are smooth muscle, which has the beta activations. And then you get swelling and mucus plugging. That's what throws the kids into the bad exacerbations and all that stuff. Dyspnea, nasal flaring, tracheal tugging, accessory, and then any of your retractions, which we talked about that. So how do we treat it? Estrogen. What? Okay, albuterol. And for EMT guidelines, diesel potentially. How much albuterol can you give? One what? What's a treatment? So under 10 kilograms or over 10 kilograms is the first question that you have to ask. So if it's under 10 kilograms, what's the dose? Albuterol? What? That's EpiPen. So under 10 kilograms, 1.25 milligrams albuterol. Over 10 kilograms, 2.5. Okay. And you can repeat how many times? Yep. Well, you can repeat 3. All right. But the scope of practice for the state of Ohio states what? If you're giving albuterol and the kid is not prescribed it, what must you get first? Mother, may I? All right. So albuterols and all that stuff, your guidelines. So from the aspect, if you're getting into the retractions, you probably have some little nasal flaring, some retractions, bad kid there. 3-minute oxygen, encourage coughing, intubate, bronchodilators. All right. So for paramedics, what else can you give? Atrovent and yep, for asthma. Epi. Uh-huh. Yeah. Salmeterol. Okay. Yep. Yep. Well, the kid's dose is what? Yep. 0.5 to 1. Yep. All right. So salmeterol, and then of course magnesium, 25 to 50 milligrams for that aspect. And advanced EMTs, of course, you give you guys the Atrovents in your guys' guidelines. Mucus. Oh, not many people catch that. Broncos of getting the beta agonist, albuterol. We do have anticholinergics, atropine or ipratropium bromide, which is your Atrovent. From the aspect, all it doesn't wheeze. Think about pulmonary edema, allergic reactions, bee stings, hot summer day, kids out playing around, they got the hives, urticaria, and all that stuff, pneumonias, and then any of her four bodies. A 2-month-old, 3-month-old that can't get around, he got something inside his mouth, and the toddler kid is running away, think about that. Exactly. Or they shoved it inside. Bronchiolitis croup, this is the time that we're seeing now. Big component is the pediatric triangle from the aspect with the respiratory. They look sick, but they're not really sick. So they, from that aspect. Don't panic. Bronchiolitis usually caused by RSV, but there's a whole bunch of different, players that do this. And what it is you actually have upper airway trapping or constrictions and all that stuff. These are the snotty nose kids that might have some wheezing, might not hear any lung sounds at all. They look like crap. They got a pulse ox of 90, 92. So the kids look bad, but they're like, hey, I feel great. 6 months to 3 years, usually it's under age of 1 is the most common for these kids. Upper airways infections, gradual onset, they can have extreme tachypnea, cyanosis, and all that stuff. And again, it's that kid that looks sick, the 1-year-old, and they got that, snotty nose. It's a clinical diagnosis. You can get x-rays and all that stuff. You'll see steeple signing, but it's really, you walk up to the kid, yep. Once you see one, if you've never seen one before, come over to my house, I can show you one. And again, kids up until age of 1, how do they breathe? Through the nose. All right. So the treatment for these kids is what? Suction, suction, suction. Okay. Piss the kid off. You got to get the nose cleaned. Suction, suction, suction. Nose breathers. If you need to, put them on some oxygen. Some kids do well, about 15 to 30%. If they have family history of asthma, giving them a breathing treatment and all that stuff. So some albuterol. Beat. So croup, this is laryngeotracheal bronchitis. Okay, this goes a little bit lower down, so it's no longer the upper respiratory. Okay, and they have the seal marking cough. Who's heard this? Has not heard it? Okay. Once you hear it once, they get that. Okay, you can across the room. You can open the door and the kid coughs, and they get that. It's characteristic. Okay. Yep, they got croup. Okay. So how do we treat this? What's the home remedies for croup? Vaporizers. Okay. So taking the kid into the bathroom, shut the door, heat the bathroom up, okay? Get the hot, moist air. Or some kids, you actually have to take them out into the cold weather. So the dry, cold weather. Don't know why it's the two polar opposites. Some do really well with the hot, cold, or the hot mist. Some do well with the cold, dry. Stuffy nose, upper respiratory airway becomes inflamed. That's what causes the barking. They can get stridor, which is that, sound and all that stuff, which is really a bad thing. And, medics, this is where you can do your nebulized epi and all that stuff to help. Sorry. Then, of course, the tachypnea. Epiglottitis, again, we're not seeing this as much. I think I've seen 2 cases over the past several years. Yeah. So this is the kids that they'll have drooling coming out of the mouth. They can't see, So what's the one thing that we're taught with EMT and paramedic school with epiglottitis? What don't you do? Don't lay them flat and nothing in the mouth. Don't look, sit them up, keep them calm as much as possible. If you can have mom hold the kid, anything to keep the kid calm. And then it's a lot of high flow diesel. And might even some, Jet A if you need be. Drooling, tripod positions, if they get bad enough. From there, comfort, don't place anything, oxygen, and then transport. Kid crashes, okay? If they stop, they become cyanotic, what do we do from there? Ventilate them if you can't ventilate them. What? Intubate or strike, okay? Knowing, up to about the age of 8, might just have to be a needle crike. So again, as EMTs and all that stuff, to be thinking about, having a 14 gauge needle readily handy there, for your paramedics and all that stuff with a 6.0 or a blade and all that stuff. Respiratory compromised, again, remain calm, reassure the child. Don't agitate them, avoid the IVs, avoid, laying them flat, and then really give them to the parent, just let the mom and dad hold them, strap them all in the car seat, and then drive. So the inconsolable child, the soul bitch, a little demonic that I talked about. Strangulation, for some reason, mom's hair falls off and wants to kill the kid. They'll wrap around the kids, or the kids will grab the hair. They'll get around the fingers, around the toes, around the penis, and all that stuff. Open pins, this is the old days where they had, diaper pins and all that stuff. So the pin was poking the kid. Anal fissures, of course, the batter, trauma, and all that stuff. Any forms of infection and the deceptions, testicular torsions, and then your colicky kids, 1-2 months, they start bringing their hands to the eyes. They look, a lot of times you can see them and they've been in a fight or something. They're just scratching themselves, so keeping their nails, clipped, teaching the parents, and then any of the hernias. So the sore bitch. Socks on hands. The seizures. From the aspect, seizures is just really any interrupted electrical activities. The biggest with the kids, of course, is the febrile seizures. We don't really diagnose it in the field. The kid has a fever, they have a seizure stops. Seizures can last up to 15 minutes with these kids. They have what's called the generalized tonic-clonic, so they go unresponsive, taking the whole body, they pee themselves, they bite the tongue, they have everything. Usually by the time that you get to them, they might be still seizing. By the time they get to the hospital, what do they look like? They stop seizing, they look good, they're starting to perk up, okay? And we just watch them. It's not exactly the temperature, so you can have, it's how fast it gets up there. Okay? They can go from 100 to 104 like that, and then that's what causes the seizures. Or they can have that slow, gradual increase, and they have no problems. Other things, febrile, number of seizures, what it look like, any head traumas, of course, ask about diabetes with older kids. Okay. Lack of blood sugar will cause seizures and all that stuff, so check your blood sugar every time. Give them oxygen. Do they get any medications? Headaches? What's the particular rash? Yep. Pinpoint red spots and all that stuff. And of course, don't forget your neuro exam, dehydration, neck stiffness. You know, the little kids up till age of 2, they get the bulging fontanelle. It's, almost looking like a geyser that's going to come out. Actively seizing, protect them, don't restrain. And then advanced EMTs and medics, what can we give? What? Versed or? Ativan, if we have it. Ativan has to be in a refrigerator. So not a lot of crews, Valium, okay? So from the aspect of Versed, okay, if you can't get an IV in, how can we give it? Nasally, up the nose and all that stuff. IM injection, put it up the butt. I don't care. Management, ABCs, vascular aspects, if you can, check blood sugar. Then, of course, treating that, and then fevers and cooling them down. All right. So for seizures, it's the lack of oxygen that causes the death, brain death. Unfortunately, I've seen this a lot in our profession, all that stuff. Febrile, again, usually under the 1 month of age with fever, is we look at doing lumbar punctures and CNS. This is why all these kids under the age of 3 months should go to the hospital because of this reason. Okay. Correct. So it is immunologic age. Okay. And that's really what we take into factor. Okay. So it is what would they be at so it's their premature age plus they're out of gestation. Now if they get beyond what they would be 2 months beyond their gestation, what their normal gestation, then they're good. So if they're premature, they're still immunologic premature. They could be 3 months old, but be 3 months premature, and they're immunologically day 0. So yes, because the thymus isn't working properly and all that stuff. Yep. Types of seizures, of course, just from the aspect with the febrile seizures less than 15. This is a simple generalized. They get 1 in 24 hours, no previous. Complex, more than 15 minutes. They get a couple over 24 hours. They might just have a focal seizure, shaking an arm, and then from some previous neurologic problems and all that stuff. The 2 different types of febrile seizures. This is the more common one with the simple. Usually associated with the virus, last 15 minutes, again, once 24 hours. Treat the fever, don't really do much more than that. Send them home. Daycare, family history, 10%. If they've had a seizure, if they've had one before, guess what? Potentially having or febrile seizures they're going to have again. And then the neonatal time periods and all that stuff greater than 30 days put them at higher risk. Males, sorry guys, we're the weaker sex. Treatment, reduce the fever, OBS, and then treat the cause of the fever. Not much more. So, going back to the prep and all that stuff. So practice. Prepare. Okay? Give you guys scenarios. That's what drill time is for and all that stuff.